All right, hello. My name is Chelsea Bali, and I'm a nurse practitioner at Children's Hospital Los Angeles, and I'm kicking off, I believe, Module 2, talking about toxicities. So this specific talk will be on cytokine release syndrome, or CRS, which is probably one of the most infamous toxicities that we all know and love when we're taking care of our cellular therapy patients. So I have no financial disclosures to report. Here's a list of objectives for this talk. So first, we'll talk about just what is cytokine release syndrome and define that. We'll review the pathophysiology behind CRS and why this happens in our patients. We'll review the general CRS consensus grading criteria and what we use to grade it based on a kind of specified scale. And then we'll go over some nursing implications. And if we have time, I have a couple of case scenarios, but we may table that as well. All right, so what is cytokine release syndrome? This is one of the most common toxicities associated with cellular therapy infusions. It's a systemic inflammatory response that's really related to the proliferation of T cells with the release of high levels of these inflammatory cytokines. So when we think about CRS, we usually think about it in the context of these big symptoms that include fever, hypotension, hypoxia, and then ultimately can lead to organ dysfunction. And we'll go into much greater detail on that. But CRS can really make up a whole array of symptoms, starting with low-grade constitutional symptoms such as flu-like symptoms, just general malaise, headaches, things like that, and then can lead into these high-grade syndromes that are associated with life-threatening multi-system organ failure. These patients can develop tachycardia, capillary leak, respiratory distress, DIC, all sorts of symptoms that can ultimately progress to shock and multi-system organ failure and ultimately death if not intervened in a timely manner. So pathophysiology of CRS, sorry, this is kind of a busy slide, but you can break it down into 5 different phases. So I think it's important to understand kind of what causes CRS to occur in the first place. So phase 1 is simply the infusion of CAR T cells as they go to the specific tumor site. And that will look different depending on what your tumor is. If it's a B-cell leukemia and your CARs are going to target these CD19 positive cells all over your body versus, a intracranial injection of CARs into a specific tumor site. So that's phase 1. Phase 2 is as these cells start to expand and activate at the tumor site. Cytokines can be produced and your T cells start to become active. During this phase, immune cells are also activated and tumor cells begin to be killed. And this is what leads into phase 3, which is where you see all the fun stuff with your patients. So phase 3 is where the cytokine levels really start to increase as your CAR T cells expand. And this is what leads to the systemic inflammatory response that we see. This is when you start to see that hypoxia develop, hypotension, potential organ damage. That's really a result of endothelial injury and vascular leakage that starts to occur with all of the inflammation that's happening. Phase 4 is when your cytokines and your CAR T cells start to migrate into your CSF and your central nervous system. This can lead to neurological changes. You may or may not see this in your patients, and this can happen with or without an actual CRS process preceding it. And then phase 5 is when things start to calm down, your tumor cells begin to be eradicated, some of the CAR T cells start to die off, and this leads to an overall decrease in cytokine levels and reduction in your overall systemic inflammatory response. So this is a nice timeline that kind of breaks down these 5 phases. If you look at the top section, this kind of shows that CRS as it starts to peak and then ebb off, and then how ICANS kind of follows that. So these patients get their, conditioning regimen for a few days prior to their CAR T cell infusion. It may vary different depending on the type of protocol that you're using, but oftentimes it's day -5 to day -3. And then they have a couple days off, and then they get their CAR T cell infusion on day 0. CRS generally occurs within the first week or so after CARs are infused, and that can vary, of course, depending on the protocol and the type of CARs that you're giving. So there are certain protocols that we have given, and again, I'm coming from a pediatric standpoint, but I think CRS in general is Pretty similar depending on what protocol you're using, but the timing of it can vary dramatically. So we have certain CAR T protocols in our PEDS patients where we know to anticipate CRS occurring within the first 24 hours, whereas other protocols that we use, such as like Kymriah, we anticipate it to happen within about 7 days. So that can vary. So you see that in the top section here. The middle section looks at your CAR T cell numbers in peripheral blood, and you can see how that kind of correlates with the onset and decline of CRS as well. And then in the bottom section here, this just shows you kind of the peaks of different cytokines. And there's different elevation in cytokines that correlate with this period of CRS as your CAR T cells are expanding. We know that there are a lot of cytokines that are activated during this time. IL-1 and IL-6 are two of the major cytokines that we know are released during CRS process and that we can target with different therapies. So risk factors for CRS, I think it's important to understand which patients might be at higher risk for developing CRS when you're managing them. So these are some of the patients that might be at higher risk for developing the cytokine release syndrome. Patients who are coming with a high disease burden. We've seen time and time again that patients who come in with high levels of disease tend to have more prominent symptoms of CRS than patients who are coming in with very low levels of disease. Patients who have had higher number of previous relapses have been known to have more significant CRS responses, and then patients who are getting higher doses of CAR T cells as well. So CRS manifestations, these are kind of the three big things that we look at when we're talking about CRS, and we'll go into more detail on how we grade it as well. But the three big things are fever, hypotension, and hypoxia. So fever, when we're talking about CRS, is defined as a temperature greater than or equal to 38 degrees Celsius. Hypotension is graded based on the degree of vasopressor support that may or may not be required. And then hypoxia, which is graded based on the degree of respiratory support that these patients end up requiring. So CRS lab monitoring. We monitor a lot of labs when our patients have active CRS, particularly when they're in the hospital and they're a captive audience. We're checking these very regularly. First is a standard CBC. This should be monitored regularly as patients might require more frequent packed red blood cell infusions or platelet transfusions during this time. These patients can develop pretty profound electrolyte imbalances. So we monitor their metabolic panels regularly, at least once a day, oftentimes more frequently if necessary. Some of the things that can occur with CRS are hypokalemia, hypophosphatemia, multiple other abnormalities that require aggressive electrolyte repletion. Coagulopathies can occur with endothelial disruption that can lead to bleeding. So we monitor coags regularly, their PT, PTT, INR. Oftentimes these patients need to be supported with cryoprecipitate or fresh frozen plasma in addition to platelets in order to prevent any catastrophic bleeding. As far as their inflammatory process goes, CRP and ferritin are really good inflammatory markers, and so we'll monitor those daily, and you can see a pretty consistent uptick in those numbers as CRS is progressing, or as it's improving too. As you start to see those numbers come down, you can anticipate maybe an improvement in their symptoms. And then a cytokine panel is something that can be sent if you want to know specifically which cytokines to target. We know from experience that oftentimes IL-6 and IL-1, as I mentioned before, are elevated cytokines that are targetable, that we have medication to treat. So we can anticipate that those will be elevated. For us, I know this, if we send this panel, it usually takes at least a few days to get back. So it's not particularly helpful in the moment, but you can often look back and see, oh yeah, these cytokines were extremely elevated during that period when we were seeing all of these symptoms, and it does correlate. So the American Society for Transplantation and Cellular Therapy, or ASTCT, put together a really nice CRS consensus grading a handful of years ago that can really be applied to anyone who's receiving CAR T cells. And different studies might have different nuances in terms of how they grade and how they manage and treat CRS. But in general, this is kind of a nice standardized way to grade it. So it breaks it down into 4 different grades, grades 1 through 4, and it's again graded specifically on fever, hypotension, and hypoxia. So like I said, fever is defined as a temperature greater than or equal to 38 that's not attributable to any other cause. And in this case, we are, it's sometimes hard to say, okay, they had a fever and then we treated it and now it's better. So now do they still have CRS or not? So we'll say if they've been treated, then we can exclude the fever when we're grading it. So then you can look at the other symptoms as well. So CRS is usually graded based on the most severe event. So for example, if a patient has a temperature of 39.5 and they're on low flow nasal cannula and they're on dopamine, they're requiring dopamine because they didn't respond to a normal saline bolus for their hypotension, then they would be grade 3, even if the fever improves, because you're grading them based on the most significant response in this table here. So this is a really nice resource to have at hand whenever you're managing these CAR patients, and you can easily look at it and say, okay, this is what grade they have in this moment. And then we talk about this every day when we round on these patients. Okay, what grade is their CRS today? What are their overnight events? How are we managing their hypotension? Did they respond to a normal saline bolus if they needed it, or are we having to escalate care? So this is just another visual way of looking at CRS consensus grading. And it has on the left-hand side here, the grading scale. And then on the right-hand side lists just kind of the different organs that are affected. So I like this because it breaks down all the different systems that can be affected when you have a patient with all of this inflammation. So it's, we're grading it based on fever, hypotension, and hypoxia, but there's so many different things that are happening in these patients. They can become very tachycardic and have cardiovascular compromise. They can have GI symptoms, nausea, vomiting, diarrhea, liver dysfunction, kidney dysfunction. They can have all sorts of cytopenias that are requiring interventions. Like we said earlier, myalgias in general, musculoskeletal dysfunction as well. So not just those 3 things that we're grading on, but it can really affect the whole body pretty significantly. Capillary leak is something that I think is an important side effect just to draw particular attention to. Hypotension is such a big factor in these patients, and we're very quick to treat hypotension with fluids, and in general, that's what's recommended is giving, starting with a fluid bolus for these patients who drop their blood pressures, but we have to be very mindful of capillary leak. These patients have a lot of endothelial damage from all of the cytokines that are being released, and so when we give normal saline for hypotension, it's easy for them to develop capillary leak, and so we have to be mindful of how much fluid we're actually giving them. We have a general rule of doing 1 fluid bolus, reassessing, and if we need to, we can repeat and give another fluid bolus. But oftentimes after that point, we would prefer to move to dopamine or some type of vasopressor support, just because these patients are so leaky and we can cause more respiratory distress as that fluid leaks into their lungs if you're pushing too much fluid for blood pressures, and then you're getting into more issues with hypoxia, and it's hard to come back from that. So just being very mindful of your eyes and nose with these patients if you're managing them at the bedside. And as providers, we have to be really thoughtful about how much fluid we're actually giving them. So supportive care and management for patients with CRS. This is really per institutional guidelines, but general things to think about: always treating these fevers with antipyretics, not leaving them febrile and uncomfortable. Antimicrobial prophylaxis and therapy as indicated. Usually, anytime we have a patient who has a fever, we would always treat it as an infection until proven otherwise. So they're still getting blood cultures drawn. We're still treating them with antibiotics, even though we can presume that in this setting, it's most likely related to a CRS component. Anti-nausea support, blood product support as needed, fluid resuscitation, again, being very mindful of fluid volume overload and the risk of capillary leak, and then oxygen support as needed. So I wanted to include some nursing practice recommendations since we're a big nursing group here. So these are some key things to be mindful of. And as you go back to your institutions, especially if you're working at the bedside and taking care of these patients, things to pass along to your teams as well. So the first is to recognize the patients who are most at risk for CRS, because we know that early identification is key. Accurate nursing assessment and early identification with initiation of interventions can mitigate the risk of CRS morbidity and mortality. And we went over kind of which patients are at higher risk already. Second, recognizing the time period during which patients are at the greatest risk for developing CRS. And this is, again, going to be based on the protocols that you're using at your institution. We know in general, CRS tends to happen within the first 1 to 2 weeks post-infusion, but again, this can vary. We have a CD33 protocol for peds AML patients that we've used, and these patients get significant CRS within the first 4 to 24 hours post-infusion. So being mindful of that, so you know to really be aware and watching for these symptoms and when they're most likely to occur. Number 3 is just knowing how to reference the appropriate CRS grading system, which is the chart that I just shared with you that you have in your books. ASTCT is always a good reference, and also just knowing what your protocols mandate and how they're grading and how they're responding to the patients on the study. Number 4, closely monitoring vital signs of febrile patients and anticipating the need to quickly escalate the level of care. We always monitor these patients at least every 4 hours, but oftentimes they'll need more frequent monitoring than that if they're having, onset of fevers and any changes in their vital signs. And then, of course, notifying providers right away of any concerning changes in vital signs. And then it's also important to talk to your critical care teams. So these patients, we've seen them when we get really significant grade 3, grade 4 CRS, they can crump really quickly. So talking to your ICU teams in advance, making sure they're aware of these patients, potentially have a bed ready, so that's not an issue. And we've seen that happen, at CHLA, where it's like, this patient is so sick, and then you're starting multiple pressors on the floor because, there's just the PICU needs their time, the ICU needs their time to prepare for these patients. So if they know in advance, we have this patient who has grade 2 CRS quickly becoming grade 3, we're afraid that they're going to need much higher level of respiratory support, talking to your colleagues sooner rather than later. And then having an understanding of CRS biomarkers that are monitored to predict and define CRS risk and severity. And those are what was listed really on the earlier slide. And then I just wanted to include this. I know this is not a TCT talk, but they have a lot of great resources for CRS. And ASTCT does have an app that can be downloaded that includes a CRS grading calculator. And so I always like to share this with people because we all have our phones on us at all times, right? And so if you have this on your phone, you can actually plug in the exact temperature, symptoms that your patient is having, and it will tell you exactly what grade CRS your patient has. It also has a lot of nice resources in terms of practice guidelines, other presentations, references that you can use with your teams as we're taking this back to our own hospitals that might be helpful as you're training your colleagues in how to manage CRS. And we're just going to be getting more and more of these patients. So it's good to have as many resources at our fingertips as we can. I'm going to table the case studies. So I think that is it.